Hello, thank you for joining me today for this presentation on ACEs and trauma-informed care. My name is Ivy Anderson. I am the Executive Director of the Parenting Place. If you're unfamiliar with us, we are a community-based nonprofit child abuse prevention center located here in Missoula, Montana. So our mission is the prevention of child abuse and neglect through strengthening families. And we do that by, one, providing presentations like this in a variety of settings. So we give them to schools, hospitals, childcare facilities, and to all of the parents that walk through our doors. So on top of this type of training, we also provide parent education in a variety of settings, including within the community, and we also offer them at the Missoula Detention Center, so the jail and the pre-release center here. So thank you again for sitting with me today to go over this information. We think it is for everybody. We know that adversity is common, and in order to prevent it, we have to be aware. So that this is kind of step one in helping us to become more trauma informed and responsive in our daily interactions. So what you can expect to learn today, one, we're going to define what trauma is and its impacts on our health. We're going to be able to see what our role is in being able to provide trauma-informed care. We'll go over the core principles of trauma-informed care and how we can apply them. And then the last step is hopefully you'll walk away from this presentation with more confidence in how we respond to everybody, whether it's, within our jobs or our families or just when we're out in the community, we'll be able to respond in a more trauma responsive way. So this can be a tough, kind of heart-heavy topic when we think about the impacts of trauma. And a lot of us, because we know it is so common, we want everybody to just feel safe emotionally, psychologically, as well as physically. So if at any time during this presentation the information is triggering or, just too much in the moment, please feel free to step away and just take time for yourself to do what's best for you. So I know this isn't necessarily a group setting, but I think this is good to know when we're thinking about presentations where we're talking about trauma. We want to protect the emotional safety of the entire group. So I always use this analogy of skipping the stone. And that just means that it's not that we're saying that we don't want to hear people's stories. It's just that sometimes when we start to share or go into deep details, it can trigger others in the room. And so we point out that, we want people to share what they feel is relevant in the time, but not sink the stone. So that's the analogy, is skip the stone rather than sink it, just to protect the safety of the group. And again, if this information is bringing things up for us, it's finding, that safe person. You can always reach out to me directly. My information or my contact information will be provided to you, and you can reach out to discuss things more or even set up, another training session. So Dale's cone of experience, I put this in this presentation just as a reminder of how we learn and then begin to apply it in, real life. So the hope here is that, you'll uh, read things, hear things, see things, and maybe write things down. That's why I always encourage taking notes. Um, but it's really how we change is by putting things into action. So that is my hope for everyone when they get these trainings is that they have learned something and then they can apply it. Because if we're not, using the information in a way that makes an impact, then it's just kind of stored in our brain. And, what really is the point? So we're all about, taking information from this presentation and being able to start applying it, day one. Okay, so let's get into it. This is what we're going to really be discussing throughout the whole training. But I like to start off with these kind of definitions on what trauma is, why it matters, and how then we can move to being trauma informed and responsive. So, this quote here is from Peter Levine, and he says, "Trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of human suffering." Right? So, this is why we're here today, because a lot of us have been told, from a really young age that we don't want to talk about these kinds of things because these conversations are hard and it's easier to kind of, brush it under the rug and just forget about it. Often people are told like, oh, it's not that bad or just get over it. And so the suffering continues because we're not able to process it or heal from it. And so that is why it matters. We are going to have these tough conversations so that we can move to a space of beginning to heal. So with that being said, becoming trauma informed, it starts with ourselves, right? We have to be able to do that self-reflection, meaning, hold up the mirror and really understand ourselves and how we may have or may not have been impacted by adversity or trauma in our lives, especially when we were children. Because, really understanding ourselves is step one, because it's kind of like that age-old saying, if we aren't aware, how can we help others become aware? So that is why it's so important when we're going through this training too, to just be mindful of how you're feeling as we go through it, and identifying who are those safe people in my life that I can have these conversations with, because that is truly how we heal, is through our connections with others. Here are some definitions that you're going to hear throughout this whole presentation, but I wanted to find them. So, adversity is circumstances or events that pose a threat to our well-being. And trauma is the outcome of the exposure to that adversity or the threats, right? And toxic stress, this is what occurs when we experience lasting threats. Because really what's happening when that's occurring is that our stress response system, you've probably heard of this, the fight, flight, freeze, fawn response, when that is overactivated, meaning we are experiencing that left and right, we're living in survival mode, when that, overactivation occurs, it leads to, or it has the risk to lead to possible health outcomes, such as, physical, mental, emotional, even spiritual harm. And I think it's important to note here, though, that adversity is different than trauma. So experiencing adversity, it doesn't necessarily mean a person is traumatized. So adversity doesn't equal trauma. It's all about our perspective, which I'm going to talk a little bit more about in the next slide. But we want to remember that trauma is a person's, own experience of what happened and their perception of what happened. So we cannot tell someone what their experience is or should be. We don't get to say things like, oh, you are traumatized by that, or you shouldn't be traumatized by that, or that's not really trauma, right? It is up to the individual to be able to define that for themselves. So like I said, trauma is all about perception, and it's highly individual. A situation that one person can easily recover from might be very traumatic for another person. So an example of that is, let's say two people experience the exact same car crash. One person might walk away from that, being a little bit rattled, but it's not something that they're going to think about long into the future. Whereas the next person, they might really never want to drive again. So another example would be children who experience divorce within their family. If you talk to one child, they might have a totally different perspective of what happened than their siblings. So again, we always want to remember that people are defining their trauma for their own self. And we always want to stay away from projecting things like, oh, it's not that bad, you could easily get over that, because it's so individual. It's about how the person feels about the stress that they've experienced in the moment. So this is a quote from Bessel van der Kolk. He is the author of this great book that I recommend checking out. It's called The Body Keeps the Score. And it's basically, I will say it is kind of a heady and scientific book, but I do recommend it because it breaks down how it is that we may not recall a memory, in our mind. However, the body will remember it. It's stored within our cells. And so I'll just read his quote here. He says, "People talk about trauma as an event that happened a long time ago, but what trauma is the imprints that event has left on your mind and in your sensations. The discomfort you feel and the agitation you feel and the rage and the helplessness you feel right now." So I like this quote because I think it helps us realize that this is not something, when we think about trauma, it's not something that just goes away. So I think it kind of sums it up perfectly with those definitions. It's again, and I know I keep repeating this, but we do not get to define for other people what their experience has been. All we can do is listen and believe, what they're telling us. Okay, so now that we've gone over some of those definitions of trauma, I want to bring us to the ACE study. So the ACEs study, it stands for Adverse Childhood Experiences Study. So when we say ACEs, that's what we're talking about, is Adverse Childhood Experiences. Now, this study was done in the early 90s, and it's always interesting to me because when I give these trainings, I usually ask people, by a show of hands, who's heard of this? And not many hands go up. This is a fairly old study that is important for every single person to know about, yet the information isn't really being spread. And that's why, when you leave here today, I hope that you'll share this information with the people in your life, because It has the ability to help bring about great positive change. Now, I want to give you a little bit of the history behind how the ACE study came about. So, these two gentlemen here, Dr. Robert Anda and Dr. Vincent Folletti, were the key investigators. So, at the time, Dr. Anda was working for the CDC, the Center for Disease Control, running a group that helped people quit smoking. And he was finding that people were having, great success. And then all of a sudden they would quit and pick up the smoking habit again. Now, Dr. Vincent Folletti at the time was working for Kaiser Permanente and running kind of the same support group, but his was for weight loss. He was finding, the same thing as Dr. Anda, that people were meeting their goals, losing weight, but then out of nowhere would drop out and gain it all back. And he was puzzled. So he decided to call in some of the participants who had quit the program for an interview about, reasons why they left when he thought they were doing so well. So he prepared some questions that he thought, might help him figure this out. And one of them, interestingly enough, was how much did you weigh when you had your first sexual experience with another person? And was shocked when one of the participants answered 47 pounds. This obviously was very disturbing to him. So he asked her some more questions, and long story short, found that she was sexually abused as a child and had recently had an encounter with a male that had approached her to ask her out on a date, and it made her so uncomfortable that she, wanted to put all the weight back on because that is how she felt protected from men. So Dr. Folletti took this information, shared it with Dr. Anda, and they thought, hey, there's something deeper going on here. We need to look at people's, whole childhood and how it relates to their health. So they decided to try to gather study participants, and this became what we call the largest public health study of all time because it had over 17,000 study participants. It was closer to 17,500 actually. And it's really hard to get that many people to partake in a study. But because Dr. Folletti was working for Kaiser Permanente, if you know anything about Kaiser, you know that they're a huge health consortium. They own the hospitals, they own the research, they own the health insurance companies. And all of these people in the study had Kaiser's health insurance. So that's how they were able to access that many people. And really what they did is just sit people down, ask them a stack of questions about their childhood and their life and their health. And they also had access to their health records, again, because of Kaiser's insurance. And what they found was shocking. It was, proven with scientific evidence that when people experience adversity or trauma early in life, meaning the first 18 years of life, it had a dramatic increase on negative health outcomes, meaning our physical health, our mental health, our emotional health, our behavioral health, our spiritual health, anything that is health related is impacted by our early childhood experiences. So that's the study, or how it began. I do want to point out the demographics behind this study because I think that's also really important to note. So the study was 50% men, 50% women. A majority, I think it was 70%, were white, and majority had a college education and were upper middle class. And they were of all ages, from 18 to, in their 80s. And why is that important? I think often when people think about trauma or adversity, they assume things like, oh, that's a, poor person's problem, or that's a black or brown person's problem. That's happening on the other side of the tracks. That's not me, right? But this study breaks down that stereotype, right? If this is happening in upper white middle class, America, it's happening everywhere. So again, the study just confirmed that when we have trauma or adversity in our childhood, it has the possibility or the risk to create health problems later down the line. And we're going to kind of get into what that looks like here in the next few slides. So this slide here just shows us some of the possible risk outcomes. And again, I want to point out when I say risk, it doesn't mean that this is a crystal ball, that if I've experienced trauma, it means I'm going to have something or all of these things on this list. It just means that our risk, for experiencing one of these or many of these things is greater than somebody who has not. So these are just some of the things. I always say this list could go out the door. When we think about disease, it's something like 95%, it's probably more than that even, 95% of disease or health problems are due to stress. And what does trauma or adversity bring? Stress, which we'll get into here in a little bit as well. But these are just some common examples. So, smoking, I won't read all of them, but smoking, alcoholism, experiencing diabetes, heart disease, cancer even, all of these things we now, with the scientific evidence, can connect them back to people's childhood experiences. So this isn't to scare people, again, like, oh, if I have, trauma in my life, it means that I'm going to have cancer. It means that if we can predict it, then we can prevent it. If I know I'm more at risk for cancer because of life experiences, then I have a starting place to help, take care of myself, or do things that are going to prevent that. Okay, so this slide here is what we call an ACE screener. So it's 10 questions, and people read the question. If it applies to them or they've experienced it, they check the box, and then they total their score. So if somebody checks, all 10 boxes, that would give them an ACE score of 10. And then we ask, do you believe that these experiences have affected your health? Again, it's about people's perspectives in life. So they might say, not much, some, or a lot. And, I will say this screener did come from that original ACE study. Remember how I said they sat all the study participants, the 17,000, sat them down and went through a stack of questions about their childhood and, their life experiences and their health. These were the top 10 questions that the study participants answered yes to. So I'll just read them again. They're just the most common adversities or traumas that the study participants had experienced. So the first one was feeling that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect you or take care of you. The second is losing a parent through divorce, abandonment, death, or other reason. The third one is living with anyone who was depressed, mentally ill, or attempted suicide. The fourth one is living with anyone who had a problem with drinking or using drugs, including prescription drugs. The fifth one, having parents or adults in your home ever hit, punch, beat, or threaten to harm each other. The sixth one is living with anyone who was arrested or went to jail or prison. The seventh one is having a parent or adult in your home swear at you, insult you, or put you down. The eighth one is having a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way. The ninth one is feeling like no one in your family loved you or thought you were special. And the last one, number 10, is did you experience unwanted sexual contact, such as fondling or oral, anal, vaginal intercourse or penetration? So experiencing sexual abuse. So again, these are the top 10 most common adversities or ACEs. I should say, people can experience things that aren't on this list, right? I've had people say, well, I watched my best friend die right in front of me, or I was hospitalized for 3 months, when I was a kid. Does that count? And it's like, yes, if you feel like something caused harm in your life, that can be viewed as adversity or, trauma. So this list, somebody could have an ACE score of 100 or 1,000, right? It's just, again, these are just the top 10 most common things from the original study. So from those 10 questions on that questionnaire, they broke it out into these 3 areas, right? So abuse, whether it's physical, emotional, or sexual, neglect, physical or emotional, and then household challenges, which were, living with somebody with a mental illness or having a relative become incarcerated. This says here having a mother treated violently, but it doesn't, we know that it's just having violence in your home. So whether it's mom, dad, or mom and dad towards siblings, it's witnessing violence. The substance, abuse or misuse issues, and then the divorce. So these 3 categories are, again, just broken down the most common ways that children experience adversity. So because this study, like I said, was done in the early 90s, we've had a lot of time to gather more information. The study is still ongoing. And I should say they are still tracking those people from the original study too, and comparing, health outcomes. So because we've had this time to learn more, we know now that people can experience adversity, trauma, toxic stress, not only in their homes, right? So the tree here, these are those 10 things, and there's some more on here added, but those are the, things that happen within our house that can cause pain, harm, suffering, right? But we know that we can also experience adversity within our communities. And that's kind of the ground here, the roots. And some of the examples of how we experience adversity within our community is things like lack of food, lack of safe housing, experiencing, racial injustice or prejudice, discrimination, lack of jobs and resources. So, so we can experience in our household, within our community, and, within our environment. So that's things like natural disasters, war, the pandemic, was very traumatic for a lot of families and communities. So again, when we think about that original ACE screener, where it's, just 10 questions, it's remembering that it can be more than just 10 things. So this here is just an example of an ACE screener for a child, right? So that other one that I showed you was one that an adult would take on behalf of their own self. This one is a screener that is filled out by a parent or guardian on behalf of the child. So it has, the same 10 here in section 1 that are on the original screener or the adult screener, but they've added more in section 2 because we know that, with more education, we have found that, oh, children are experiencing even more than just what's on the adult one. So I highlighted some of the things here that are very, very common now for children. It's, experiencing foster care, harassment or bullying is huge. Another one is experiencing deportation or immigration, having a serious medical procedure or life-threatening illness, experiencing violence in your neighborhood or at school. And then the last one is being treated badly because of our race or our sexual orientation, our place of birth, having a visible or invisible disability, or in our religion. So it's important, in my opinion, these things should be added to the original adult one as well, but we'll get there one day. But because again, these are things that aren't only just happening nowadays, this probably happened to a lot of people, when they were kids, even if it was 60 years ago. This is an important fact that came from the ACE study, and it's that if we experience one ACE, the chance that we'll experience another is 87%. And it might even happen at the same time. So an example of that, if you think about those ACE screeners we went over, let's say I am witnessing violence within my home or my community, right? That gives me an ACE score of 1. Now, because I'm witnessing this violence, the chance that I will become a victim to it or I'll be on the receiving end of it, 87% chance. And that it might even happen at the same time, right? So I think this is important to remember. This is why we want to prevent ACEs, because once we have one, highly predictable that we can have more. This graph here is looking at the number of ACEs a person has, or what their ACE score is, compared to their risk for health problems. Now, scientists like to use what they call the dose-response relationship, and it basically means, the more gas I put in my car, the further I'm going to be able to drive. Now, when we plug the ACE data into that dose-response algorithm, what we found is that the more ACEs we experience, the greater increase for risk that we have with health problems. And the interesting thing was that they started to see a spike in, health issues when people had an ACE score of 4 or greater. So the 4 or more was kind of the tipping point of seeing that increased risk. When we look at some of the increased risk for people when they have an ACE score of 4 or higher, these are just some of the statistics around how that plays out. So a person with 4 or more ACEs is 12 times as likely to attempt suicide, 10 times as likely to use IV drugs, and almost 7.5 times as likely to become an alcoholic. So when we think about this statement at the top that the gateway drug is trauma, that's what is influencing these types of behaviors. And it's important, to shift that lens of, why would somebody, use IV drugs? Or why can't you just quit drinking? What would ever possess you to attempt suicide? right? It's trauma, it's unhealed pain and suffering that leads to these increased risks of health issues or behaviors. This is what trauma does. It overwhelms our ability to cope. And if we are a child that grew up with adversity or trauma and toxic stress and didn't have somebody in our life to help us learn healthy coping mechanisms, that's where the increased risk comes from, right? I want to again point out that it's all about perception, right? Traumatic experiences are more than just upsetting. Biological changes take place, and it affects how people cope and react in situations, based on past experiences. So think about, that fight, flight, freeze, fawn response. We've all had that and behave or react differently in those situations where we feel a threat. And we're going to talk more about that stress response here in a few slides. So building off that last slide with our, ability to cope, this graph here is demonstrating, what that looks like when we don't have, that healthy, competent person in our life that helps us through adversity or trauma. So you can see here there's 3 different types of stress. We have the positive stress, tolerable, and toxic. Now, with positive stress, some of the examples here are, falling down on the playground or losing at a sports game. Those things are healthy for us. It helps us build confidence in our abilities to overcome challenge, and it also can help us learn and grow. So you can kind of see here, there's this trend going throughout these 3 columns of a hand, right? We call it the buffering hand. And that is the support that we need in order to lower our risk for health issues. Now, in the original ACE study, they state that we all need at least one person in our life who's this buffering hand, this safe person for us, right? Without that, that's where that greater risk for health issues comes from. So going back to the positive stress, if I fall down on the playground and scrape my knee, I don't necessarily need a buffering hand. It's nice if I have somebody that's like, oh, darn it, that hurts. Let's, get you cleaned up. But if I don't have that buffer, it's not going to lead to, long lasting health issues, right? But it's different for the tolerable and the toxic stress. If I'm experiencing, death of a loved one, I don't have, the buffering, caring support that I need, the likelihood then that I fall down here to the bottom where it says adaptation and recovery are likely, but there's potential for lasting harm, right? That we need that buffer in order to keep us afloat. And it's the same thing with the toxic stress. If I'm experiencing physical or sexual abuse and I don't have this buffer, this safe person that can help me process that and learn some, healthy coping mechanisms, I'm at greater risk again, falling down here to the bottom where the consequences are more severe, as things like heart disease and even cancer. So it's again, the positive thing to look at is that it just takes one person and we can be that buffer for anybody, in our life. And also knowing that we need that buffer in our life too. So identifying, who is the safe person so that I can deal with the challenges of life in a healthy way. Now we're switching gears a little bit here, but in order to really understand the ACEs study and why it is that there's a connection between experiencing trauma or adversity and then having a greater risk for health problems, we have to be able to understand how the brain works. So I'm going to go over these next few slides, really just some of the basics in order for us to see what's happening inside the brain when we experience stress. So there are three main parts to our brain that I'm going to go over with you based on this top illustration here. So starting with the red section, this is our brain stem. And our brain stem is responsible for things that we don't have to think about, like our breathing and our heart rate or our body temperature. All of the things that are necessary for us to be alive, right? But it's also responsible for checking and assessing the environment for safety. So it's constantly asking this question, am I safe? Now the second section of our brain is this blue area here. This is what we call the limbic system, or the emotional center of our brain. So earlier when I talked about, the fight, flight, freeze, fawn response, that is where this is located, within the limbic system. Now, another interesting thing about the limbic system is it's where we store memories, right? And our memories are also connected to emotions. So if you think about a time that you were, super happy, if everybody can recall that right now, you will also feel that happy emotion, right? So the purpose of that is so that, again, we can assess for safety, because we're going to be comparing the situation that we are in to our memories and our past. Now, the third section, this top part of our brain, is what we call the neocortex, but we're specifically looking at the green section here, which is, the prefrontal cortex. Now, it's responsible for things like using logic and reasoning and being able to plan into the future and our, language skills. All of that is located within what we call, the executive state. So these three parts of the brain are working together and constantly asking these questions. Am I safe? Am I loved? What can I learn from this? Right? But the main function, or like this says, the primary function of our brain is simply survival. Okay, so what happens in our brain when we experience stress? So Dr. Dan Siegel developed this hand model to kind of just give us a visual, a simple visual of what is going on when we are scared or stressed out, right? So as you can see, I'm going to use my little laser pointer pen here. We have the three main parts of the brain, right? We have our spinal cord, which represents the wrist. We have the limbic system here, which is the thumb. That's our emotion center again. And these are our survival, states. And then covering this are the fingers here and here. This is our prefrontal or neocortex. So when we think about our nervous system, there's two parts, right? We have rest and digest, and then fight, flight, freeze. So here, where it's, the fingers are closed over the top of the thumb, this is rest and digest, right? We're calm, cool, collected. But when I get stressed out or I perceive something as a threat, what happens is that we flip our lid and we're in this state here. We are in survival mode. We're in fight, flight, freeze. Okay, so the body doesn't know the difference, really can't perceive the difference of a threat being, a bear coming at me, or, the bear being my teacher yelling at me, or, somebody bullying me on the playground. The body responds in the same way. This is a threat. I don't like it. I don't feel safe. So I'm going to be here. Fight, flight, freeze. And now this is an important function for us, to flip our lid and be functioning here in survival mode. But it's unhealthy for us after about 20 minutes. Our body is not designed to live here, in this mode for more than 20 minutes. Because when we get stressed out, or, we're feeling like we're being threatened, the body releases cortisol. And cortisol is healthy for us. It's going to help us, get out of a situation. The cortisol and the adrenaline are going to help me run or, fight. But if all day long we're flipping our lid, that cortisol, or we're in this state with our, fingers up in the survival mode all day long, it's hard on the body. That cortisol and adrenaline pumping through our veins all day long is unhealthy for us, right? We're not designed to live in survival mode all the time. And so when we think about why is it that experiencing stress or trauma leads to negative health outcomes, it's because of this overactivation of this response system, right? Our bodies want to be here in rest, digest, calm, cool, collected. It's necessary to have this function for survival, but we're not designed to live here all day long. And so that's what we want to remember. Anytime we're even feel like we're starting to flip our lid, what can we do to calm ourselves down? And people do that in many different ways. It's, again, our coping mechanisms. Learning how to do deep breathing, learning how to even just put on some music that's calming or take a walk. But we have to be able to identify it, before we're already in fight, flight, freeze mode. So this slide is showing us kind of how our brain gets wired with our experiences in life. So I like to begin by pointing out that we have these single neurons here. And at birth, I have as many of these as there are stars in the sky, right? Just waiting to be connected. So anytime we experience something, it creates a connection in our brain. So that's demonstrated here. You can see these little lines. These are our neural pathways connecting these single neurons, right? So an example would be, let's say I'm here, at birth, I'm a baby, and somebody yells at me. I'm crying and somebody yells at me. It makes this connection. This neural pathway is that this person is scary, I'm not safe, and I don't trust this person, right? Or it could be the flip side where I'm crying and somebody comes and picks me up and soothes me. It's going to make another connection, right? Oh, she's nice. I like that person. I feel safe. So by the time we get here to elementary age, you can see that this is like a jumbled mixture. This is a process that our brain, we call it arborization. So it's like trees, they've all grown together. It's kind of a tangled web of experiences. So that by the time I hit adolescent years, you can see it's kind of thinned out here. There aren't as many. It doesn't look as, as crowded. This is a process that our brain goes through called pruning, where kind of like trees, we cut out the branches, prune the branches that we don't need anymore or that aren't serving us any purpose, right? Everybody's brain goes through this process of pruning, and what remains are the connections that are strongest. You can see some of them are darker here than others. Those are pathways that I I like to think of these neural pathways as like a dirt road. The more I travel down a dirt road, the deeper those grooves are going to get, right? So that's why some of these are darker. So our brain is being wired with these experiences. So let's say I'm here again and I'm the baby who's crying, and every time I'm treated, poorly, that is going to be a connection that I keep. That, people are unsafe. I can't trust people. Same thing for positive experiences, though. If every time somebody comes and soothes me when I'm crying, that's still a connection that's going to last, in my brain. Now, I get this question a lot. People are like, oh, well, does that mean that, your brain doesn't change ever after you go through this process of pruning? No, the answer is no. We can always build new neural pathways. It's just as we get older, it's harder, we have to repeat things more and more, to develop a new neural pathway. So it can be done, they call it neuroplasticity, where we can, create these new neural pathways even into adulthood. It's just, again, as we get older, the process is a little slower. So thinking about, how our brain is wired, I like to make these comparisons here between, a safe world and a dangerous world. And how is the brain of a child in a safe world maybe different than one from a dangerous environment? So let's say, we'll just give them names here. Let's say this little one here, this is little safe Sarah. She grows up in a world where she's like that baby, where every time she cries or, is feeling scared, there are people there to surround her and give her that safety and support. So her brain is adapting to that environment where she believes in people. There's processes to things and there's possibilities in life, right? So now on the flip side, we'll call this little guy Danny. And Danny comes from a dangerous world where when he feels scared or stressed out, there aren't people, that surround him with that support. So he lives here. His brain is adapting to the world that, with the flipping of the lid, that this is happening for him more often than it would for Sarah ever, right? So in the past, we used to call kids from Danny's world here, we would call them maladaptive, and the root meaning of mal is bad, right? So that's what Danny, that's the world he's living in, where there's something wrong with him. He's bad, right? And we want to change that narrative, because here's the thing. The way that little Sarah and little Danny's brains are developing, it's an adaptation to their world around them, right? It's not that it's good or bad. It's just that when Danny lives here in fight, flight, freeze all day, it's negatively affecting his health, right? It's not that he's bad. It's that it's just bad for him, But I always like to point this out, that when we become adults, our adaptations, the way that our brain is wired, can be both positive and negative, right? So just because Danny is growing up in a dangerous world, the positive is that he's learning to survive in even the worst conditions. Whereas little safe Sarah down here, she's learning, her brain is being wired to survive in the best conditions, right? That's what she knows, but then is vulnerable in the worst. So if we were to, put these two in two different worlds, if I were to put little Sarah up here in Danny's world, probably not going to be, Her brain is not wired to survive in the worst conditions, right? She's going to be vulnerable. But for little Danny, same thing. If we put him down here in, Sarah's safe world, it also doesn't mean that he's going to have those skills, those survival, skills in a safe world, because what he knows is danger. And so there are positives and negatives to both of these worlds. I want to point out that there's something to learn from each other. Little Sarah has a lot she can learn from Danny, and Danny has a lot to learn from Sarah. These are just kind of the extremes here, but most people are a mixture of both of these worlds, right? The reason I always show this slide is so that people see that just because, Danny has grown up in a scary or dangerous environment, it doesn't mean that he doesn't have skills. Like, who would you want walking with you down a dark alley at night? Danny, who's used to surviving in the worst conditions and probably knows how to avoid that or get out of that situation. Whereas, Sarah walking down the dark alley might just freeze and not have any skills of what to do. Okay, so there's this guy. His name is Martin Teicher, and he's a neuroscientist. And they brought him in to review all of the data and findings from the original ACE study, to make sure that all of this brain science was correct before they could publish the study. And this is his quote here. It's that when our adaptations collide, the adaptations are the way that our brain is being wired, right? That's our biology. When that collides with what the social expectations are, that's where we run into trouble. It's not that Danny's brain, little, Danny from the dangerous world, it's not that his brain is being wired to survive in, scary or negative situations. The problem is how we view Danny in the world. So the example I'll give, let's say again, this is little Danny and this is his dad yelling at him because maybe Danny, got up late for school. But the reason he got up late is because everybody was partying around all night. So he, didn't get any sleep. And maybe he went to bed without dinner, or maybe there was some fighting and arguing going on. Right? So when you think of that ACE screener, the ACE questionnaire with the 10 things that, children can experience as adversities, let's say Danny's experiencing all of those, right? So he's sent off to school without a hug and a kiss goodbye, probably not any breakfast. And when he gets there, it's again, the social expectation of him is that he sit still, listen, don't try to talk to your neighbors or make connections. Don't fall asleep in class. The expectation is that Danny's brain is not wired, like little safe Sarah's. He can't just sit still, because he's flooded with that cortisol. And so the real problem is how we treat people who are, experiencing stress. Because if Danny went to school and people knew, that his brain isn't wired to just sit still, listen, pay attention, don't talk, and we punish him for it. Stop talking, Danny. I'm going to move you to the front of the class, that kind of thing. When that happens, Danny, it kind of becomes a self-fulfilling prophecy. Danny already has a lot going on, but society, or the environments he's in, whether it be school or, out in the community or in his neighborhood, the way he's being treated by others kind of compound the situation. And so Danny's being told that he's bad, right? And that's the problem, If you've ever heard of this study, it's called the school to prison pipeline. This is where it begins, right? Because instead of Danny being treated, you know, differently because he needs more support, instead of saying, hey, Danny, do you need to take a little break? Do you want, do you need a little snack? Like, what's going on? Rather, he's punished for it. And so within that school to prison pipeline study, when they asked people who were experiencing incarceration, how old were you when you first got, kicked out of the classroom or sent to the hallway, or sent to the principals, or maybe even, suspended for the day or even expelled for the year? How old were you? Majority said they were in second grade or younger, right? So that is the problem. That's where the trouble begins. It's not how our brain is being wired, it's how we're treated because of how our brain is wired. So we're changing gears a little bit here now. So far, we have covered, that ACEs are common and they're interrelated, meaning that once we experience one ACE, there's a high chance that we'll experience more, and that they're powerful. So one thing that we haven't talked about yet here is this intergenerational transmission of ACEs. And this is also known as historical trauma. Sometimes people call it multi-generational trauma. It just basically is the study of epigenetics and how we can pass trauma down to our children. So a lot of the time when I talk about this, people are very skeptical and want to know how it is that we know this and why this happens. So I'm just going to tell you about a simple study that kind of helps people wrap their brains around it. So this study was done on mice. And what they did was they took a group of mice and they had them in cages, and they would shock them through the wires of the cage. And while they did this, they would release a cherry blossom scent, right? So I'm going to try to kind of slow it down a little bit so we can all absorb this. So they took the mice, shocked them while releasing cherry blossom, right? And pretty soon, what they did after that, a few rounds of that, was remove the actual electrical shock, and they would just release the cherry blossom scent. And all the mice had a trauma response, right? Because the brain had been wired to make that connection that cherry blossom equals bad. Cherry blossom is dangerous because it means physical harm, right? So with the next generation of mice from that group, they did the same thing, but they never actually executed, the shock. They just released the cherry blossom scent. And again, same trauma reaction. They all freaked out, like, cherry blossom equals bad, I'm in danger. Because the DNA had been changed. In order to protect their babies, their DNA was passed down so that they would know to stay away from anything cherry blossom related because it meant threat, right? So then with the third generation, it was the same thing. No shock, just cherry blossom scent, and same trauma response. So this was passed down 2 whole generations before it was no longer in the DNA, or that had been kind of switched off. So the idea here is that the reason, this exists is for survival. Again, that is our whole, mission in life, is just survival. And so when we think about historical trauma today, we see it, play out in many different groups who've experienced trauma throughout their ancestry. It is still alive and well. So that's why we don't want to say things like, well, that happened, 300 years ago or more, if we're talking about slavery or the genocide, between, Native populations here in the US. So it's, it's a very sensitive topic, and the studies are still ongoing. But the reason it's still alive today is because we haven't removed that shock. So it keeps getting passed down. And an example of that, I'll tell you, not too long ago, I had a parent call me and say that her child, was afraid to go to school, didn't want to go to school anymore. And, when I inquired to why, they were both afraid to, she was afraid to send her son to school, and, he just wasn't going to go. So she was looking for options on, what to do. And when I asked, well, why is he afraid? Is there bullying going on? And she said, yes, but it stemmed from a note being passed to him that had the N-word written on it, right? So that is the shock, right? That keeps getting passed down. It doesn't have to look like it did in the experiment with the mice and be an actual physical shock. It's a reminder, it's a memory. It's stored within our cells and passed down in order to protect, ourselves and our children. So this next slide, I'm going to try to play a short little clip on how, again, this is so impactful to communities. So before I play the little clip or voiceover recording, I just want to touch on a few more things about historical trauma and just point out that it's, the effects of trauma are felt as a ripple effect. People who've experienced this trauma or who are around those who have experienced the trauma can feel the effects too. And the wounds and the consequences of trauma exposure affect, all the following generations. So it's, a collective experience of trauma by a group of people, with shared identity or affiliation or circumstance across generations. So I'm going to try to play this little voiceover. It's an example, just one of many, of historical trauma described by researchers Gilson and Ross. And this is from an article in 2019 called From Generation to Generation, Rethinking Soul Wounds and Historical Trauma. So let me see if I can play this. Okay, it's not going to let me, but I'm just going to read then the passage from this article. Okay, so each year, members of the Lakota tribe and their allies gather in Bridger, South Dakota, to travel more than 300 kilometers on horseback in the dead of winter. The conditions are harsh. Wind and snow burn their faces, and it's hard to breathe. They travel to commemorate the journey of their ancestors. After the killing of Chief Sitting Bull by the U.S. Cavalry, Chief Bigfoot led approximately 350 Lakota, mostly women and children, on what he hoped would be a journey to safety to the Pine Ridge Reservation. Instead, they were intercepted by the U.S. Army. Their group submitted peacefully and made camp along Wounded Knee Creek. On the morning of December 29, 1890, a shot rang out and chaos ensued. Those who tried to flee were pursued and executed by U.S. soldiers. Children hid and were coaxed to come out and were then killed. All told, more than 250 Lakota were massacred. Although this tragedy took place more than 100 years ago, its impact remains. The ongoing pain from the genocide of the Lakota and numerous other acts against Native Americans has been described as a soul wound. It is what drives the Lakota horse riders in search for both personal and communal healing. The past weaves intricately through modern life, and in some ways, communities are still trying to recover. Now we can all just take a deep breath, because I know that is it's painful to hear, and especially for somebody who has experienced that. That's why I think, calling it a soul wound is a perfect way to describe it, because it isn't something that just leaves you. And I think this is the proof and the evidence that people need to know that this is why historical trauma still does play out today, even if it happened hundreds of years ago. This slide is another example of soul wounds and how they play out still in society today. So this is highlighting implicit bias here in this news story about Hurricane Katrina. So as you can see on the left here, the caption is 2 residents wade through chest-deep water after finding bread and soda from a local grocery store. And then on the right, the caption reads, "A young man walks through chest-deep flooded water after looting a grocery store." So here's where this implicit bias, by media outlets and community members, still impact the BIPOC community. There is real historical oppression. And what happens when somebody looks at this is an example of the shock that I was talking about. It leads to heightened stress responses, right? So, when that happens, when people's stress, responses are heightened, they may be more fearful for their lives, due to these prejudices. I mean, the Black Lives Matter movement is a direct response, to racism that's still pervasive in our society today. So it's, this oppressive language matters. And it's important to highlight, these subconscious biases that people have, because even though, whoever wrote these news articles, they may not have been meaning to harm somebody or groups or communities, but that doesn't mean that they didn't. It absolutely still perpetuates, the cycle of harm. So this is a quote from Charles M. Blow. He writes for the New York Times, mostly around social justice or human rights. So he says, "One doesn't have to operate with great malice to do great harm. The absence of empathy and understanding is sufficient." Right? And I really like that quote. I think it's powerful because it's so true. If we don't have awareness and understanding, we run the risk of causing harm or more harm or perpetuating the cycle of harm. And that's why, I'm so thankful that you're here today listening to this, because it helps us build our awareness, right? We don't just do one training and then say, "Oh, I'm trauma, informed and responsive. I'm an expert now." This is lifelong learning. And so to be open to that and aware of that is how we're going to influence change. So what is re-traumatization? And this is why I like that quote from Charles M. Blow, because it just shows, that without, that empathy and understanding, we do run the risk for re-traumatization. So the definition here is, a situation or an interaction or even the environment, that replicates events or dynamics of a prior trauma, and it triggers feelings and the reactions associated with that original trauma. So, if with re-traumatization, it can be obvious or not so obvious. So an obvious example would be, placing a rape victim in restraints, or yelling at somebody, raising our voice to somebody who's experienced verbal abuse. It could be also, not so obvious, with an example being, even as simple as, closing the door to your office to allow for privacy. So somebody who was abused behind closed doors, that act of shutting them in a room may be triggering for them. So it's important to remember, that it's usually unintentional. We're usually unaware that we're replicating abuse because we have a lack of knowledge around that person's, life experience. But just because it's usually unintentional, it is always hurtful. It exacerbates, the very symptoms that brought the person into services in the first place. And it can lead to things like self-injury, suicidality, paranoia, and just more perceived danger and a lack of trust. So this next slide I'm going to show you is, ways that we can think about this and how it plays out in systems and what we can do to just be aware to avoid re-traumatizing a person. So this chart is just some examples here on how systems are really set up to re-traumatize people. It's the policies and the procedures, saying things like, this is the way it's always done. But if we're not aware of these and how they play out, we do run the risk of re-traumatization. And so it's taking a look at our systems and making those changes, even though it's maybe the way it's always been done, there is still room for change. So I'm just going to give you the example of the first top things on this chart and how they can play out. So the example I always give is, with going to a new doctor, right? Like we've all experienced how that goes. Like usually, you fill out a new intake or paperwork either ahead of time or in the waiting room. And then you're finally called back to the exam room and the nurses ask you to elaborate on your answers, right? Then, you wait around for a little while longer and the doctor finally comes in and then asks the same questions again. It's frustrating, right? We think, can't they talk to each other or read my chart? We've all experienced, some annoyance or frustration, from that scenario. But again, it's how it's just done. But for a person with trauma, they may be triggered with past feelings of, not being seen or heard and thinking, I just don't matter, or they don't really care about me. And what happens is they flip their lid, and they might not come back for the services that they really need. So this is, why it's important to take a look at these systems and how are they actually working for everybody. So remember, re-traumatization is usually unintentional, but we need to think about these things so we're not causing harm. That is what it means to be trauma-informed. So this is how the cycle of trauma works. It illustrates the difficulty that people have in healing from trauma when people around them don't understand the behaviors in the context of trauma, meaning that we just aren't trauma informed. So you can see, this is how the cycle plays out. A traumatic event or situation happens. It creates this sense of worthlessness or inability to trust or just being hypervigilant on the lookout, for danger all the time. This usually then leads to us engaging in counterproductive actions or behaviors, again, because many of us weren't taught those healthy coping mechanisms, or we don't have a safe person in our lives to help us deal with the trauma or process it even. And then it leads, to people around us, reacting negatively based on our stereotypes or beliefs. And then when this happens, it just confirms what the people thought, the person who experienced trauma thought in the first place. Like, I'm worthless. Nobody cares about me. This world is just unsafe. So what we really need to do is interrupt the cycle when and how we respond to people when they're in this yellow circle here, when they're engaging in, actions or behaviors that we find negative, or counterproductive. So, while we may not be in the role of actually treating trauma, we can still disrupt this cycle, by being trauma informed and being deliberate in our approach so that we're not re-traumatizing. It's what our role is to neutralize the environment, rather than make it worse. So it's not really an intervention. Being in trauma informed is looking at these types of situations with a different lens, in changing, how we respond in order to disrupt this cycle. So what is our role when it comes to being trauma informed and responsive? So we have 3 different levels here. There's trauma informed, trauma sensitive, and then trauma specific. So trauma informed is, like it says, for everybody, the entire community. It's, thinking about how we provide support that promotes healing. We recognize that many people have experienced trauma, especially as children, and we create opportunities for people to experience a different response to the world by creating safety and trust, right? So being trauma informed, applies to all of our interactions and the environment that's anchored in the 6 guiding principles of trauma informed care, which we'll be going over here soon. But it's just, every person should be educated and trained on these principles that we're going to be talking about, in order for us to use this as, like it says here, a universal precaution. So taking a universal precautions approach is as simple as recognizing, again, that many people have experienced trauma and we should treat them as such. So the example I give with that is comparing that to a medical, provider. They always put on, their exam gloves with each and every patient. They don't ask us, do you have a bloodborne disease that I should know about before, we begin here? They just put the gloves on because it protects themselves and, their patient. So it's the same thing when we think about using a trauma-informed approach. We don't have to ask people, what's your life story? What are all the, traumas you've experienced throughout your life? We simply respond to everybody in the same way, as if they may have some traumatic experiences in their background. Now, for the second level here, being trauma sensitive, again, I feel like this is for everybody. Everybody, can take this approach as well, but it's more specific to teachers, caseworkers, people providing, direct support to individuals. So trauma sensitive means, making the decision to use, evidence-based trauma screenings and assessment tools, and we make deliberate changes, to the environment, which could be as simple as, looking over our policies and procedures, that address potential for re-traumatization. And that is complex. I give whole trainings, on how to do these 6 guiding principles or assess them within, your work. But it's simple little things make a big difference, like looking at the lighting of the space. Do we have locks on doors? Do we have proper exit signs, that direct people on ways to get out of the building? So even just those simple things can make a big impact on the safety of not only, the people that we're serving, but also fellow staff members. So this last one here, the trauma specific, that is for people who are trained, licensed in providing this kind of trauma treatment. So things like EMDR, CPT, seeking safety. There's many different levels of, evidence-based interventions. But in order to provide that type of care, we need to have the education in the background. So again, it's everybody can be trauma informed and trauma sensitive, but in order to actually treat the trauma, we want to make referrals out to people who have this trauma specific, background. As mentioned earlier, we get into this, the 6 values or principles of trauma-informed care. So here they are. Safety, trustworthiness and transparency, peer support, collaboration, empowerment, and humility and responsiveness. So these are necessary pieces of being trauma-informed and responsive in our interactions. So it's important to remember or just recognize that these are already working, and these concepts are interwoven. So for example, they are all helpful on their own, but they aren't sufficient alone. So with that, we can't trust if we don't feel safe, right? And, if we're not empowered, then, it's hard to make choices or collaborate. So it's just keeping that in mind, that all of these are working together. We have to have all of these in place to actually say that we are coming from a trauma-informed approach. So that just means that to play all of these out, it requires this knowledge, from a person who understands the role of trauma in a person's life. And we're serving then, as being a partner to them. So I'm going to go through each one of these just to kind of give you a breakdown of how we can understand each one and apply it. So the first one we'll start with is safety. And that means both, being physically safe as well as emotionally or psychologically safe. And that means assessing, for the physicality of it, asking questions like, where are we meeting? What security is offered? What is even the appearance of a waiting room or an exam room, an office, a classroom, a bathroom? Is personal space offered? Is it accessible to people who may be using a wheelchair, for example? All of these things, need to be looked at when we think about, physical safety. But, also the psychological and emotional piece of that is, asking like, am I being, welcomed? Or am I welcoming people? Are the interactions respectful and engaging? Safety is just, it's always going to be step one. If people don't feel safe, none of these other things can happen. So moving on then to the second one here, the trustworthiness and the transparency. Trust, it requires honesty and openness and transparency in, the relationship building and the communication. Trust creates conditions for the healthy connections that we need in order to grow and feel safe with another person. So it's things like maintaining confidentiality, and providing a consistent routine or structure so that we all know what to expect. We also want to be able to understand our roles and responsibilities and how we're communicating. We want to make sure it's clear and consistent, and also that we're setting boundaries and that they're maintained. So that would be step 2. It's again, safety is what we start with, and then the trust comes in next. But again, these all kind of are, like I said, interwoven together. But these have to be in place if we're actually coming from a place of being competent in providing trauma-informed care. So this third one, the peer support, it means that we're inviting people with a shared experience into all of our conversations and decision making. It's kind of like the saying, if you've heard of this before, the quote is, "Nothing about us without us." So that means we cannot, make rules and regulations or policies without the voices of those that are, being impacted by that. So it's ensuring that decision making, happens with other people involved with that shared or lived experience. Okay, so the fourth one here, the collaboration. Sometimes this is called voice and choice, but it just means shared decision making. We as humans do not like being told what to do. Even if we know it's good for us, if somebody tells us to do it, we kind of become resistant. It's just, human nature. And often, people who've experienced ACEs or trauma, they have often lived in environments where they really had no control or choices. And so very often they already feel that, they have no choice in how they live their life. Life just happened to them. So we as trauma-informed individuals, can create trauma-informed environments by allowing people, whether it's children or adults or just anybody in our life, whether it's work or home, it's always offering some freedom of choice. And starting small, I will say, that offering too many choices, especially for somebody who's never been given choice, it can feel overwhelming. So, to start small, it's as simple as, if we're working with a child, giving them 2 different options for meals or 2 different clothing options. If we're thinking about staff, it's, offering staff members the freedom to choose their break times, or giving clients an option on, times to meet that fit their schedule, rather than, just saying you need to be here at this time and show up. I think the systems have been set up that way where it's like you show up at this time or else. And that is not, being trauma informed. So the point being is, we all need voice and choice in our lives. And it really is easy. It's an easy practice to incorporate into a trauma-informed approach with people. It's just adopting the understanding that people are indeed the experts in their own life. Okay, so the fourth one here is empowerment. And, empowerment considers how all interactions and, procedures within a system are affirming or validating and really just built on people's strengths and skills. You know, empowerment can provide the support and encouragement that a lot of people need, in order to move forward in their lives. And I will say we can't always assume that, everybody struggles to do this, but, empowering people doesn't hurt. It can be very beneficial. And it's, again, if, you can recall the universal precautions approach that I talked about, we're not going to cause harm by empowering people and building them up. We just provide it just in case, right? So it's important, to remember that just validating people and emphasizing growth, it just ensures that individuals have a, voice in planning. So the sixth one, the humility and responsiveness. I mean, this is last, but definitely not least. This, to be humble and responsive, it basically means the first step is that we have to become aware of our own implicit bias and the stereotypes that have basically been baked into us from childhood, from our environments, from our family, from our school, to the cultures that we, have been brought up in. If you have a notebook out right now, I want you to write this down and just Google it. Just write down Harvard Implicit Bias Test. And if you Google that, the first thing that should come up is the link to this test. And there's, a bunch of different areas that you can test your own bias on, but I recommend doing it because it will help you do your own self-reflection, and help you understand the interactions that you are having with others, and hopefully help you improve them. So, another thing about this principle is that it's acknowledging that historical trauma is real. We kind of already went over that in some slides, but also recognizing, to be humble about that we all need more education and training to address it, and we should be seeking that out. So those are the 6 guiding principles. I could honestly do a whole presentation of 2 hours just on this and how to assess this within your own life or your own organization or job. But because we don't, have the time for that right now, this is just an introduction, and these are just the basics. But I do encourage you, to learn more about these 6 guiding principles and how to incorporate these things, just into your daily life. If we're taking these 6 things and, constantly assessing them for ourselves and for the environments that we're in, we're on the right path. So this is kind of, it just builds off the last slide that we saw with the 6 core principles. These are the 4 R's of trauma-informed care. So we already talked about these, realizing it's widespread, recognizing signs and symptoms of it, responding with that compassion, that care, that empathy, and then really trying to resist the re-traumatization. And this stuff takes practice. Again, like I said, it's lifelong learning. So anytime you get the opportunity to, pick up a book about it or attend a training or, presentation like this, I always encourage people to do it, because this is how we're going to be a part of this movement of creating, trauma-informed communities. So to commit to becoming trauma-informed means that we are committing to a new way of thinking, because, being trauma-informed isn't about, adding more work to our busy lives or schedules, or even making excuses for other people's behaviors or even our own. It's instead about approaching people and seeing them through a new lens. And it's this lens, that can help us see people in ways that, maybe allow us to be more thoughtful with our actions and our words and even our ability, to provide care or services. So it's again, trauma-informed care, it is an individual approach. Everybody kind of has their own style and ways that they um, use it, but it has the ability to make lasting, changes to our communities, organizations, and even the culture as a whole. You know, becoming trauma informed can potentially even save lives. So this is what we call the trauma informed care mantra, right? It's switching this question, switching our lens, and instead of asking, what's wrong with this person or what's wrong with you, when we find ourselves, in the moment thinking that or wanting to say that, it's stopping ourselves and shifting the lens again, and instead asking the question of what happened here or what happened to you, because it's simply about suspending judgment, and taking a step back. And really, this is a simple question in shifting how we can do our work or do relationships better or more effectively. Because, people are not just bad people doing bad things. They're hurt people in need of healing from experiences of trauma that are ultimately, disrupting their view of themselves and the world. So it seems like a small step, but it has great power in helping people heal. It removes the shame and blame and makes you a person that somebody can maybe trust and open up to. It gives them a different view of themselves, then, that the world isn't full of just all scary people. There are people who care and that are here to help. This brings us into what we call resiliency. And how does one become resilient? So, people can be born with a certain level of resiliency, right? It's again, if we can pass down trauma, we can also pass down resiliency, right? People can be born with this, and we can always build it as well. And these are just some of the things that need to be in place in order for us to build it or maintain it. We all need healthy, positive relationships and connections, social support networks. It's again, with this whole perspective taking, being able to put ourselves in other people's shoes and see things from different perspectives. I won't go through all of these for time's sake here, but just know that if we can have, negative or adverse childhood experiences, we can also have positive childhood experiences. And studies have shown that those positive childhood experiences can counterbalance, and build resiliency, and which then leads to less, negative health outcomes. And so if we put a lot of focus there on how to change this world for our children and for others in general, it's thinking about how can we create those moments. How can we be able to give that caring and that healing, just in our presence with people. That is going to help others build, this resiliency, and it help, in exchange helps us as well too. Now I want to talk about this term, post-traumatic growth, or PTG. So post-traumatic growth is different than resiliency. Resiliency is a personal quality, like I talked about, that you could be born with, and also you can cultivate it and grow it based on the experiences and the people in your lives that help you through things. So that's what resiliency is. It's our ability to kind of make it through challenges, especially, traumatic challenges, and get to the other side. But the difference with, PTG and resiliency is really that some people can use their traumatic experiences to their benefit, right? Like, for example, somebody who has experienced something traumatic can take their story and then use it out in the world by sharing it, to help others heal. So that's post-traumatic growth. I will say that post-traumatic growth, it's a process that takes significant, time and energy and dealing with difficult emotions. And so we cannot expect this of everybody. We cannot tell somebody like, oh, what doesn't kill you makes you stronger. Or, what have you learned from your trauma? You should be able to, use this for your benefit. Because the fact of the matter is that nobody should experience trauma. It's just never okay. Right? So that's why we just want to be careful when we think about post-traumatic growth, because it really isn't for everybody. And I mean, it's incredible when somebody can use their trauma to benefit themselves, but we cannot have it be an expectation on everybody who has experienced trauma. So this leads us to taking care of ourselves. I think, a lot of the time when I talk about self-care, people are like, oh no, not this again. She's going to tell us to, go take a bubble bath and everything will be better. Just get a cup of tea and forget about it. But that's not what self-care is at all. I like this definition where it's taking an active role in protecting our own well-being and happiness, especially when we're experiencing stress. Right? That is what self-care is. We have to actively be a participant in it. So this is just one example of how we can become a more active participant in our self-care. So it's basically just assessing our needs and how we're getting them met in each one of these areas. So we call these needs our spices. And I know that sounds a little corny, but it really is, the spices of life. And these are the needs that are common to all people, no matter your age or your background. Everybody needs these things. So the acronym SPICES, stands for our social needs, our physical needs, intellectual, creative, emotional, and spiritual needs. So I think this is going to be a part of your little homework assignment, but I want people to write down at least one or two things that you are doing to get your needs met in these areas, right? How do you get your social needs met? What are you doing right now to meet your physical needs or intellectual needs? A lot of people struggle with the creative needs. They're like, I don't need that. I'm not an artsy person. But it doesn't have to just be art. It really can be as simple as our clothing choice or how we wear our hair. Just our personal style is a way of expressing ourselves. So the last two here, how are our emotional needs getting met? Do we have the love, the trust, security, and what are we doing to cultivate that and maintain it? And then the last one, I also get a lot of questions on this. People will say, like, I'm not very religious, so I don't think this applies to me. But it doesn't have to be just, finding meaning in life through religion. It can be, spending time in nature or volunteering. So these are all like very individual to each person. And if you think about these on a scale of, 100%, some people might say that social needs are 50%, of what, how they get their needs met, because maybe they're really extroverted. Whereas a, more introverted person might be like, oh no, social needs, that's 10%, right? So think about that too. On the scale of 100%, how do you feel like this relates to you? So I always encourage people to, not only just sit down and come up with, one or two examples of what you're doing, but also rating yourself on how, well am I doing in these areas? Maybe I need to put a little more focus on this because I, have been putting it on the back burner. So another thing I want to point out with this is for why it can be helpful to us is in times when our behavior is maybe negative, maybe we just yelled at the dog or slammed the door, something like that. It's coming back to this list because this slide could actually read needs equal behavior or behavior equals needs, right? So when our needs are met, we're feeling good, right? When we feel good, we behave good. I know that's not the most, intellectual way to put it, but it's true. And it's true for the flip side of that too. When our needs aren't met, usually our behavior is negative. When we feel bad, we are behaving bad. So this, plays into being trauma informed as well and providing trauma informed care, because instead of, asking that question like, what's wrong with you? Why are you behaving like this right now? It's thinking about the needs, like, okay, there is a missing need here, or this person wouldn't be behaving in a negative way. So not only do we apply this to ourselves and do that self-reflection of like, okay, I'm starting to get stressed out, or I'm acting in ways that, aren't beneficial to me or those around me. What do I need right now? So applying it to ourselves and then helping, others do that too. What do you need right now? What could I help you with right now? So although, the spices of life might seem, like I said, a little corny, it actually has a lot of power for us. So I suggest, screenshot this, stick it, in a drawer. It's not something you need to do every single day, although that's probably beneficial. But especially in times when our, behavior is negative, take a look at this and do, that little self check-in. So this slide comes from the Center for Youth Wellness, and I know that, it seems simple. We all know these things, getting enough sleep at night or getting, a healthy meal in is going to, make us feel better, right? But I put this in here just as a reminder because sometimes when we're not, going through the checklist of our spices or these domains of wellness, we can forget or put it on the back burner. So it's not to beat ourselves up and be like, oh no, I never, get enough regular exercise or I don't get out in nature. It's just being mindful of it. And then again, trying to actively plan. Maybe you don't actually have time to, get out in nature and take a hike. So what then could you do? Maybe just take a walk around the block, or even just stepping outside and having the sun on your, face for even 5 minutes. We don't want to beat ourselves up over this, but we do want to take an active role in maintaining our health. So these are just some self-care tips here. Again, they're very simple, but I think it's a good reminder that, our self-care doesn't have to be this big complicated thing, but when we start practicing, it's going to get easier, and we'll probably start to just do it without thinking. But the first one is just remembering that self-care is different for everybody. What one person does to take care of themselves might not be what benefits another, and that it can also fluctuate and change, over our lifetime. We do develop new interests and hobbies, and that's okay. The second one, I think I've stressed this enough that we actually do have to make plans for ourselves. And sometimes even just writing it down to hold ourselves accountable, like, I will be in bed by 10 p.m. tonight. Other things can wait. My sleep is more important. We want to be or have that active roles to ensure that we really are taking it seriously and it'll get done. And that's kind of the keeping the conscious mind part too, is just being aware, doing that self check-in. How am I feeling? What needs, maybe have I been putting on the back burner? And then trying to plan to meet those. I like this fourth one with create a no list, because I think we've been conditioned as humans, even from a very young age, that it's not okay to say no. And if we do say no, somebody's gonna be mad at us or we're gonna be in trouble. But really, it's self-love to be able to identify the things that do not serve you. And it's okay to say no, right? And it even can be things as simple as like, nope, I will not be on my phone during dinner time. Simple things like that. So create your no list and try to stick to it. And then this last one, I like this one too because it's so simple. They say laughter is the best medicine. So, maybe instead of watching a true crime documentary before you go to bed, maybe try to watch something funny. It's just, again, not taking yourself too seriously and knowing that, life can be hard. And when we find the opportunities in just everyday life to laugh and find joy, it's ultimately going to serve us well. So this is a little recap. We're getting towards the end of our presentation here. But just remembering that adversity is not destiny. It's like I said, it's not a crystal ball. It doesn't mean that because I have adversity or trauma, I'm going to end up with health problems. It just means that if I know I'm more at risk, if I can predict it, then I can take steps to prevent it from happening. And that's where all of that self-care stuff comes in, with the needs and the domains of wellness and those little tips. And then again, remembering to practice as much as you can of shifting the question from what's wrong with you to what happened to you. Because if you remember our slides of, little Danny from the dangerous world and little, Sarah from the safe world, it's not their behaviors, necessarily that are the problem. It's the way that the brain is wired and how society is treating them based off of that. So I like this last one. It's remembering that, compassion and that empathy and that kindness that we show people is the beginning of restoration, right? It doesn't, we don't have to go to this fancy training or do some deep dive, curriculum to learn how to be kind, right? It's when we think about how people heal, it's through connections with others, right? And it's the oldest medicine. Connection and compassion really are the oldest medicine. Now we're getting down to the last couple slides here of this presentation, and I'm ending them with two quotes here. So this one says, if unresolved trauma can store itself in our muscles, fascia, organs, cells, and the rest of our physical body, so can joy, gratitude, abundance, love, and peace. Your body is also a safe space. Now, I wanted to put this in here because sometimes when we talk about or have these conversations around just trauma, it can feel really heavy and sometimes depressing. And I want us to remember the hope, that we do have the ability to still find joy and gratitude and this, abundance, love, and peace every day. So I hope you can walk away from this training today with, pieces of information that you can use, and also this, sense of hope as well. This is the last slide before we get into some of the knowledge checkpoint questions, but I think it sums up what being trauma-informed and responsive is all about. So this quote is from the hero, Mr. Rogers, and he says, "Anything that's human is mentionable, and anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. The people that we trust with that important talk can help us know that we are not alone." And I just love that quote because, like I stated earlier, compassion and connection are the oldest medicine. So remember the slide where I talked about stress and that buffering hand? We have the ability to be a buffer for anyone in our life. Simply asking and listening and believing is really a profound form of doing. So thank you again for, taking the time to go through and listen to this presentation with me. I hope that you've gained some new perspectives and, have a commitment to this lifelong learning that this involves. Now I'm going to take you through the next few slides are the knowledge checkpoints. There's 10 of them, and then there's a self-reflection question at the end. So question 1, yes or no, can a person have an ACE score greater than 10? Question 2, true or false, the higher one's ACE score equals an increased risk for health problems in life. Question 3, true or false, people can experience exact or similar events of trauma and have different perceptions or perspectives about the event. Question 4, what is the brain chemical responsible for toxic stress? A, serotonin, B, adrenaline, C, cortisol, or D, oxytocin? Question 5, what is the brain's primary function? A, health, B, connection, or C, survival? Question 6, where is the emotion center of our brain located? A, brain stem, B, limbic system, or C, neocortex? Number 7, what do you call the process that our brain goes through where neural pathways that are no longer being used are eliminated? A, arborization, B, pruning, or C, priming? Question 8, true or false, historical or intergenerational trauma is a made-up theory? Question 9, true or false, we can re-traumatize someone without being aware? And last question, true or false, genetics can contribute to resilience? Whoops, I guess this is the last question. It should be 11. True or false, having a high ACE score means one is destined for health problems? So lastly, we have our reflection questions. And the first one is to identify at least 3 things that you currently do or that maybe you would like to do that will help you take care of yourself. And then the second one is think about one thing that you've learned from today's presentation that you can begin using right now in your daily life. Thank you again for your time. If you have any thoughts or feedback or questions, please reach out to me. This is our website, parentingplace.net. You can contact me there, and I'm always happy to talk. So thank you again. I hope that you have a beautiful rest of your day.